Today my topic is about the imaging, specimen, and intervention of ASD and the VSD. So I'll show you the percutaneous closure of ASD and the VSD using specimen. So we will touch about the anatomical issue in percutaneous closure of ASD and the VSD. The anatomical, the slide please. Anatomical issues in ASD closure is rim, the interatrial septal rim. The length of the rim is important. And for closing of VSD, the muscular base is no problem at all, but for closing of perimembranous VSD, AB block and the aortic valve regurgitation is a big issue. So as you can see, this is the embolized septal occluder, which has a left atrial disc, right atrial disc, and the waist. And the left atrial disc, the rim length is 7 millimeter, and the right atrial disc rim length is 6 millimeter. So theoretically, the rim length, the heart rim length should be longer than 7 millimeter. It's adequate. But in clinically, at least more than 5 millimeter. This is the cartoon of the atrial septal rim. As you can see, this is the aortic rim and SVC rim, IVC rim. This is the mitral rim, and this is posterior rim. Most of the ASD is located at the anterosuperiorly, so the aortic rim is maybe absent or very short in most cases. And for closing ASD by a device, most important structure is the posterior rim. If there is a posterior rim is too short, we cannot close it very well. Okay. This is the case, embolized case. The embolized to the LA and to the LV. And I would like to show you the one case of erosion case. The above one is before device closure, and the 2 months after the heart is bigger, because at the beginning, the ASD device is well aligned to splaying over the aorta on the posteriorly, but 2 months later, it's flattened because it is a memorable alloy, and especially RA disc pinch the aortic wall posteriorly, and it develops a fistula. So this is the surgical view. As you can see, this device and this hole, and after removing the device, you can see the hole. So Dr. Amin described about the mechanism of erosion like this. When the heart beats, the aorta and the device move opposite direction, and just like a seesaw movement, and after a long time, there may be some erosion and the fistula formation. So he emphasized the importance of the length of the anterior rim, but in many cases there is no sufficient anterior rim, but we have rarely observed this kind of serious complication. So next I will show you the specimen. This is the case of ASD with Eisenmenger case. As you can see, the RV is enlarged. And as I open the heart specimen, as you can see, there is a big hole in the interatrial septum. This is SVC. The SVC rim is sufficient, and this is a posterior rim is adequate, and the IVC rim is adequate. So it's good for device closure. But however, as you can see, there's anterior rim is absent in some area. So in this case, this is a device, not so we from the femoral vein, IVC, and cross the ASD and open the LA disc like this, and pull back. When you pull back the device, the problem is it can be prolapsed. The first touch to the anterior superior portion first, and so one of the technique is rotate the whole thing to the posteriorly and open the device. It's more safe, not prevent the prolapse, and then open the RA disc like this. Okay, and so from the RA side, it's good, well aligned for the septum. From the LA side, sometimes in the big ASD, and if the mitral rim is short, this device may touch the mitral valve leaflet and make a hole in the valve leaflet. In Sejong General Hospital, we have experienced one case of mitral valve erosion and surgically corrected 4 years later. So we should check all the things. When the anterior portion is directly behind the aorta, so it may make erosion, but I have never experienced this kind of complication. And also, it does not directly touch the aorta posteriorly. There is a transverse sinus. This is very thick. So actually the incidence of erosion is very rare, but if it occurred, it can be a serious complication. So just emphasize the importance of the rim length. I have experienced 2 cases of AV block after the device closure. If the inferior rim is too short, it may touch the AV node. As you can see, where is coronary sinus? Coronary sinus, APCIS, coronary sinus, and tendon of Todaro, and the superior margin of the septal leaflet. It makes a coarse triangle. There is an AV node. So if the inferior rim is too short, the device is touch the AV node and make complete AV block. Okay, this is
do you think this device is too big or too small?
It's a little bit small because it does not cover the anterior portion. Yeah. Usually bigger device and usually device playing over like this, aorta, posteriorly, the device like this. Mm. Okay, this is for ASD closure. And
Dr. Kim,
yep.
What is the best, good for visualizing that posterior limb? You think the TT is needed at every time, or because it's hard to see that part?
Posterior.
Yeah, posterior.
So in the echo, using a short axis view, you can measure the distance, the length of the posterior limb. And sometimes in the adult, it's very difficult to measure. Then we usually check the CT in adult patients to measure every length of the limb.
Yeah. In fact, this patient was not heart transplant case that the pulmonary trunk is dilated and right ventricle is dilated, and heart and lung together was transplanted and removed after surgery.
And next, I moved on to the perimembranous space closure. The first case of perimembranous closure using unplugged perimembranous VSD. So for closing a perimembranous VSD, AV block is a big issue. In some report, usually using a PMBSD, plus PMBSD, 5% AV block reported, and in Toronto group, in cases, infant case, 22% prevalence. So it's so high. So we did not use the plus perimembranous VSD no more. But there are the most frequent prevalent congenital heart disease is a VSD. So the first Dr. So will explain about the conduction system using this specimen.
Yeah, as we know that the conduction is very important for treatment of VSDs, either surgical or device closure, we should consider about the danger of damage to conduction system. It's very clear that superior leaflet of tricuspid valve and septal leaflet of tricuspid valve together locates the location of the membranous septum here. So this is the location in danger. But if we go further in detail, that it is a continuation of AV node, which is in triangle of Coho, and it's underneath the membranous septum. So if for example, in this case, there is a membranous septum, and there was a VSD here, but the conduction should go underneath the VSD margin. So when we use device to close the VSD, in this case, we should consider not only conduction system, but also the danger of damaging tricuspid valve leaflet, and also even in aortic valve leaflet from the other side, there is a very close proximity of aortic valve like this. So it is really important to consider the damage to the adjacent structure when we close the VSD by device.
This is a case of perimembranous VSD with aneurysm.
Mm-hmm.
It's right coronary cusp and non-coronary cusp, and there is a perimembranous septum. There is a hole, but it's spontaneously closed before. But I think, as you can see, between these two cusps, there is some space. So if we use any kind of device, it may not touch the cusp directly. Okay, we can see another specimen using VSD patch. This is a patient who had surgical closure of VSD before. It's a septum.
We are looking at the VSD from the right ventricular side. So this is ventricular septum on the right side. This is right atrium. And this is the superior breaching tricuspid valve leaflet and anterior papillary muscle lifted above so that we can see into the perimembranous VSD. Now it is closed by patch. So we are now closing this VSD by device instead of patch.
Yeah. This is a cocoon device. This is similar to the AMPLAS-1 and modified to close the perimembranous VSD to prevent the AV block. So it means it's softer and a little bit longer.
Yeah, it's very soft.
So I insert it and open it on the and both sides. Okay. The size is not well matched. It's a little bit bigger device. So when you see the LV side, I would like to show you the aortic valve leaflet. Oops. Can you see? It's a little bit big device, but it's under the aortic valve leaflet, even though it's big. But the problem is there is a left bundle branch, and so the device touched the left bundle branch. So as time passed, there may be a fibrotic change. So bundle branch block may occur. On the right side, this device covers the whole area. It's a AB bundle traverse under this device. So if the distance between two discs are too short, as time passed, it flattened and compressed the AB bundle. So one mechanism is the compressing the AB bundle, and the second one is fiber optic change may cause the AB block. So many doctors use the steroid in case of the AB block. It may it may be associated with the fiber optic change. So sometimes it works well. Mm-hmm. But the problem is recurrence. Mm. So I do not like this kind of device for closing a perimembranous VSD, because even though it's softer than the original M+1, it may cause AB block. So I prefer use the M+ ductal occluder, PDA occluder. It has a left side disc, but no disc on the right side. Right. So if I implant in the VSD, it may not compress the AB bundle because there is no RV disc. So it's a little bit bigger one. Theoretical. So I have performed more than 30 cases of perimembranous space closure with AD01.
But what we should consider is that we may damage the conduction axis from the left side, but we are not suturing this margin, but we are attaching something on it. So it is not that dangerous compared to suturing this margin. Okay. So, and also the pressure of left ventricle is higher than the right ventricle, so that left ventricle pressure will push the disc to the right side, so that it's appropriate to use this kind of ductal occluding device. Okay. Can we ask him to?
Yeah.
Could you show us in this view where is exactly the moderator band? Sometimes the VSD closure can cause some issues when you cross from the moderator.
Yeah, moderator band is not a constant structure, but it's a variable case by case. But if it is, please show this. If it does block the device, it can be considered, but moderate band itself is a free floating band between the septum to the free wall. So I don't think moderate band will great danger in any case.
So not danger. What happens is when you cross, sometimes you cross with the wire too deep in the ventricle, and you get caught in the moderator band. Right. And you have to restart the whole procedure.
Moderate maybe, I think the coda may be a cause of the, yeah.
So moderate band, not only moderate band, but anterior papillary muscle itself can be blocked to trap the device within the right ventricle. But we can, interventionist should have a technique to withdraw the device.
So this is the PDA device. It's a cross it. It's a little bit bigger one, and I open it, and on the left side
yeah,
it's okay. On the right side, I should show you that it does not touch the AB bundle like this. There is no disc. It's just protruded to the RV side. It may not touch his bundle, so it may be safe.
Yeah, it is safe from the right side, but problem will be from the left side. Still, the conduction axis is exposed to the endocardium, so it may be necessary to make us a kind of plagette-like tissue, so to protect the endocardium from the device.
Now, in another company, they considering an observable device. Maybe ideal one.